If no, then we move to the. Thank you, sir. Our next presentation is by Dr. Harjeet Domra. He will be speaking on ILD, new ACCP guidelines to diagnose, workup, follow-up, and management, and how to manage the fulminant ILD with hypoxemic respiratory failure. The audience is knowing Dr. Harjeet. He is a senior consultant at Sterling Hospital and one of the director of Ashray Associates. And Dr. Harjeet for presentation.
Good afternoon, friends. The focus of my talk is going to be on acute respiratory failure in a patient with interstitial lung disease. So, as I do with most of my talks, it will be a case-based approach. This will be following the guidelines, but those guidelines won't be as evident, and we'll just summarize with the guidelines at the end. So this is a patient of mine which I saw last year. She was a 42-year-old female and came to me in the August of 2013. She had been a known case of lupus since the last 15 years. She had comorbids of hypertension and hypothyroidism. And till 2012, her disease had been mild and she barely needed steroids, and she was maintained with HCQS. In fact, what happened was that she started having gross hematuria and proteinuria in October of 2012, where she was taken for investigations. A renal biopsy done at that time showed lupus nephritis. And so the rheumatologist at that point of time started her on pulsed methylprednisolone, which was given in the dosages of 1 gram for 3 days, followed by IV cyclophosphamide on monthly basis. Following the IV pulses, she was tapered to maintenance steroids, and following 4 courses of cyclophosphamide, she was tapered to oral mycophenolate mofetil. The dose was around 2 grams per day. However, even after therapy, which was so aggressive, she relapsed with lupus nephritis again 1 year down the line in August of 2013 with recurrence of hematuria. What the rheumatologist did at this point of time was that he continued MMF, but he decided to pulse her again with methylpred for 5 days. Along with that, he added rituximab, which was given in the dose of 1 gram, and he also added cyclophosphamide, his target being that this patient is relapsing on maximal therapy and he didn't want to play around. So he was started with methylprednisolone, followed by rituximab, followed by cyclophosphamide. All this therapy was given over 5 days from 8th to 13th of August. Now this is where the story starts. 3 days after completion of therapy, this lady landed up in the hospital. Her chief complaints obviously were hematuria, which was ongoing for a month, but in addition to that, she had low-grade fever and dry cough. Very importantly, she had developed breathlessness over the last 3 days, had small volume hemoptysis also for the last 3 days, and she had lost some weight in the last 6 months. This was her X-ray on presentation. In the emergency room, vitals were a mild temperature, a respiratory rate of around 32, and saturations on room air were around 78%. She was given around 10 liters of oxygen by mask, and her saturations rose to around 96%. Now, along with this X-ray, she also came to the ER with a CT scan because the physician on the way to the hospital said if the X-ray doesn't show anything and the patient is in respiratory distress, let's get a scan done. And as you can see very clearly that there are airspace consolidations bilaterally, symmetrically, with a gradient from the apex to the base concentrated on the basis and very minimal pleural effusion. Now, this was a CT when she started off in the hospital. At this point of time, any of us seeing this patient would have a huge differential diagnosis. This was an immunocompromised patient with lupus coming into the hospital with therapies ongoing for the last several years and just been pulsed with high dose of steroids. So it could be a pneumonia, it could be community-acquired, hospital-acquired. She was an immunocompromised patient. This could have been an ARDS. It could have been an ILD along with lupus. It could be tuberculosis. Tuberculosis could never be ignored. Alveolar hemorrhagic syndrome, embolism, vasculitis. It could just be LVF, or it could be something which is totally different. In fact, at this point of time, it would be so difficult to predict. And all what we could keep as a diagnosis was this lady was suffering from acute diffuse parenchymal lung disease. Now, diffuse parenchymal lung disease basically, or interstitial lung disease as we commonly know these disorders, are a long list of disorders, and they are classified into 4 basic components. DPLDs of known cause, which would include drugs, and I'm not going to name all of them. The common ones which you commonly see are methotrexate, amiodarone, which are there in day-to-day practice, but there is a long list of drugs which can cause drug-induced ILDs. Following inhaled agents, if they are organic, then they are commonly known as hypersensitivity pneumonitis. If they are inorganic, we name it as pneumoconiosis. Then there's a long list of commonly known causes. These are connective tissue disorders, particularly infections, atypical pneumonias, viral or bacterial Legionella mycoplasma present with diffuse lung diseases. Pneumocystis pneumonia is one common example, and tuberculosis, particularly miliary tuberculosis, would present as a diffuse lung disease. Not only that, some malignancies can present as interstitial lung disease like lymphangitic carcinomatosis and bronchoalveolar cell carcinoma. So that is a big group of interstitial lung diseases which has a known etiology. Other known etiologies are sarcoid and berylliosis, which are classified as granulomatous disorders. And then there is the miscellaneous group like LAM and histiocytosis, which we rarely see. But the bulk of diffuse parenchymal lung disease comes from these group of idiopathic interstitial pneumonias, which are 7 different kinds, the commonest being the idiopathic pulmonary fibrosis, which accounts for almost 60% of idiopathic interstitial pneumonia and is the commonest variety of ILD seen in clinical practice. Now, not all of these diffuse parenchymal lung diseases would present acutely. There are very few of them which can present acutely. Infections and drugs are the commoner ones. Collagen vascular disease can have an acute presentation. Hypersensitivity pneumonitis can come acutely. IPF with acute exacerbation comes acutely. And the 2 commonest idiopathic interstitial pneumonias which come acutely are acute interstitial pneumonia and cryptogenic organizing pneumonia. Now, these are the common ILDs which we suspect when dealing with acute presentations. But along with that, you also need to think about vasculitis, diffuse alveolar hemorrhage, and pulmonary edema. And all this to put together would make a huge differential even if you are dealing with interstitial lung disease. Basically, when you're dealing in the ICU with an acute diffuse parenchymal lung disease, you have 2 basic differentials. Either it is an infection or it is a non-infectious diffuse interstitial lung disease. And the presentation of these ILDs, if we focus on the ILDs, could be like this. It could be a rapid deterioration of a pre-existing diagnosed ILD. That means the patient had an ILD and has come to the hospital with an acute exacerbation. This exacerbation could have come up from cardiac decompensation. It could have been an embolism. It could be an infection, or it could be drug-induced. Or it could be just progression of the disease itself, like you have acute exacerbation of asthma and COPD. You can have acute exacerbation of ILD. Or this could be a first-time ILD which comes to the ICU and you have no way of knowing whether this is an ILD, and this can come with an IPF which was undiagnosed, or the 2 common ILDs like I mentioned before, acute interstitial pneumonia or cryptogenic organizing pneumonia. So these are the 2 forms of presentations where ILD is present to the ICU. What I want to show is that there has to be some suspicion of non-infectious causes when a patient with diffuse lung disease enters the ICU. Why? Because the management of this group of disorders is grossly different, and initial management with systemic steroids would have a bearing on prognosis. So what did we do? We landed up with a lot of investigations. The blood gas showed hypoxia, sugars were marginally high, counts were 17,000, urine still showed hematuria, the PCT was normal, the BNP was marginally high, creates were good, echo showed moderate pulmonary hypertension. So the patient was shifted to the ICU, but she continued to worsen and she landed up on non-invasive ventilation. So my question to the audience would be, what would be your provisional diagnosis? With those investigations, are you dealing with an infection or is it a non-infectious disease? Anybody can take that, we don't have a lot of time. What would you suspect? Audience, infection, non-infection? Non-infection, a lot of you say non-infection? Okay. So then what would be your first option? Masterly inactivity, how many of you would just wait and watch? Very few, just raise your hand. Broad spectrum antibiotics and antifungals at this point of time? A couple of them. 1 gram methylprednisolone at this point of time? A few of you. IVIG at this point of time? Suspecting none of you? How many of you would investigate this patient for the bronchoscopy with a BAL? A couple of you. A BAL and a biopsy both? None. A surgical lung biopsy. How many of you would just refer this patient? Rheumatology consult, an ID consult, an intensivist consult, and a pulmonary consult. This is bad for business. You need to refer. You need to refer. None of the above. Fine? So basically, there is a long list of things which you could do, but the first and the most important being you need to rule out infection. And exclusion of infection is not easy in a patient with diffuse lung disease. So what about non-invasive investigations? Is the CT sufficient enough to rule out infections in this group of patients? Well, this was a small study published in 2000 from the American Journal of Radiology, and a very good study. They took 2 radiologists, independently gave them 90 CTs. They didn't tell them anything about the patient, didn't tell them what was the clinical picture, what was the pathology, what was the biopsy. and they asked them to identify what were the causes of these diffuse lung disease. Surprisingly, they could differentiate between infection and non-infection in almost 90% of the cases. But once they started identifying what kind of infection, whether it was bacterial, viral, mycoplasma, the specificity went down to 60%. Moral of the story, CTs can differentiate between infection and non-infection, but what specific infection, the CT is not going to be able to tell you. And that is why CTs might not be sufficient. So if your radiologist tells you that this is a fungal infection, please don't rely on him. There is no way of being 100% sure that on the CT you are dealing with a fungal infection. And hence, you need to go for invasive investigation. And the BAL is mandatory in these groups of patients, particularly if they have diffuse lung disease. Now, if the patient is already on the ventilator, the BAL is the easiest thing to do. But many of these patients are in acute respiratory distress, they are on rebreathing masks, they might be on non-invasive, and in these groups of patients, doing a bronchoalveolar lavage can be life-threatening because these patients who were spontaneously breathing end up going on the ventilator and you have landed up with an iatrogenic complications. So doing a BAL is not the easiest thing to do. If BAL is difficult, then biopsy is even more difficult because these patients have acute respiratory distress. But why would you attempt a biopsy? Simply speaking, this small paper shows you that the biopsy almost confirmed the diagnosis in nearly 3/4 of the patients, and it led to change in therapy in almost 60% of the patients. Although there were complications, but if given a choice, given the time, if the patient's relatives understand the risks associated, it is well worth a try. So would you biopsy every patient? Not necessarily, particularly the ones who have progressed despite therapy, if you suspect a non-infectious cause, and always try a biopsy in a patient who is immunocompromised. So whether it is HIV, hematological malignancy, or a patient on immunosuppressive therapy, these groups of the patients would give you definite benefits on biopsies. Not a lot of us do surgical lung biopsy, but occasionally, if the bronchoscopic biopsy doesn't give you the result, you might attempt a VATS biopsy, although this is not being done commonly. So what we did, this patient was breathing on NIV, she was comfortable, we attempted a BAL. The patient barely tolerated a BAL, so we could not do a biopsy, but post-procedure, the FiO2 went up to 100%, and the ABG showed on a 100% FiO2 a PA of just 56. Question was, I'm dealing with an interstitial lung disease, would I intubate this patient? She might be difficult to wean off, she's immunocompromised, I might lose the patient if I go on the ventilator. So what would be the best option? The audience, how many of you would intubate this patient? Very few. How many of you would continue non-invasive? Very few. A lot of you don't know what would be the best option. So let's see what things are and how we would progress. The first and the foremost thing when dealing with interstitial lung diseases, you need to classify. Why? Because simply the prognosis of each and every variety of interstitial disease is different. And the commonest one, which I mentioned previously, the idiopathic pulmonary fibrosis, is the one with the worst kind of prognosis. The prognosis, 5-year survival for IPF is hardly 10%. So what happens is, when dealing with an ILD in the ICU, the fundamental question is, does this patient have IPF? And if the patient has IPF, he is destined to die. It is not well worth trying to save this patient or gentleman or this lady if you palliate them with non-invasive support. So that is the diagram. I'm not going to get into the details. If it is IPF, do not ventilate. What about it if it is not IPF? Well, then you need to assess the longitudinal behavior of the disease. If it has been a sudden worsening in a background of relative stability, please be aggressive, which means take them to the ICU, try and biopsy them, put them on the ventilator. However, if the acute worsening is on a background of progressive fibrotic disease, then it would be better to palliate these groups of patients. What about if it is the first presentation? Then judge it individually. This patient has been diagnosed with ILD for the first time. You did not know that this patient has ILD. The likelihood of successful outcome should be the key consideration in deciding whether you would ventilate this patient. Although it is not always possible, try and reach a diagnosis. The first question to be asked is the disease potentially reversible? If the answer is no, then the palliation should and trial of NIV should be the way to go. However, if the answer is yes, be aggressive, try and identify the cause and treat it with ventilation. What about pharmacotherapy in these groups of patients? High-dose steroids is the way to go. So almost 750 to 1 gram per day for 3 consecutive days. And if the patient fails therapy with steroids, then you have a second option of using immunosuppressants, cyclophosphamide being the commonest drug to be used. And cyclophosphamide might be repeated as frequently as 7 to 10 days in these groups of patients if the response is less than prompt. Just bear in mind, if you're dealing with vasculitis, cyclophosphamide becomes the first drug of choice, even in front of steroids. So basically an algorithm, patient with ILD comes with acute respiratory failure. The first question you ask yourself is, does the patient have IPF? If the patient does not have IPF, be aggressive with the patient. However, if the patient has IPF, then you need to know what is the trigger. Whether it is a secondary trigger like pneumothorax, infection, embolism, failure. If the answer is no, this is acute exacerbation without trigger, please bear in mind palliation is the way to go. However, if there is a trigger, try and identify it and treat it. What happened to our patients? She was intubated. She was initially requiring high FiO2. Subsequently, we had to sedate and paralyze her because she was not maintaining saturation. So the question was, how would you ventilate this patient? So a lot of you said non-invasive, some of you said invasive. NIV is an attractive option. Why? Because this patient is immunocompromised. She is prone to infections. The moment you put in a tube, she's going to get infected. Also, we also know that if this is IPF, this patient is bound to die. So maybe why not continue NIV? But unfortunately, most of these patients have very high minute ventilation requirements, and NIV probably does not suffice in trying to achieve adequate saturations. And hence, we need to ventilate a lot of these patients. Ventilatory strategies in most of these patients is like ARDS, that means low tidal volumes, but please don't give high PEEPs because there is inhomogeneity as far as ILD is concerned. Use high respiratory rates and practice permissive hypercapnia. Sometimes paralytic agents might be needed. So that is what was done. This patient, luckily for us, stabilized at 48 hours. She was just started on some broad spectrum antibiotics and low dose steroids. Her BAL cultures came back as negative. She was extubated at 48 hours and completely weaned off the non-invasive because we gave her NIV post-extubation in 48 hours. 4 days down the line, 20th of August, we repeated the scan. This is 4 days from the first scan. Beautifully clearance. This is what the comparison looks like. You can see a lot of alveolar consolidations and you see a complete clearing at this point of time. Any of you, what was the final diagnosis? I don't have a lot of time. I'm going to give it to you. This was drug-induced interstitial lung disease. Rituximab was the culprit. In fact, this is a nice review. Just came out from Germany in 2012. All of you are interested in drug-induced ILD. Please read this. Rituximab is one common drug which causes this. There are 450 different drugs which can present with ILD, and a long list, and there are no pathognomic signs. It is a diagnosis of exclusion. What about rituximab in particular? This is a study which came out in 2013 in rheumatology. And they have clearly shown that the incidence is not uncommon. At least 17 patients out of the 99 reviewed ended up being on mechanical ventilation. And this last study, which I'm quoting from 2013, just summarizes my talk. In fact, what would happen to ILD patients admitted to the ICU? And this was a retrospective single-center study. They looked at 72 patients coming with ILD to the ICU. A few of them with drug-induced, a lot of them with fibrotic interstitial pneumonias, and others were classified as miscellaneous. Now look at this data. In fact, in-house mortality with interstitial pneumonia was nearly 70%, but lower with drug-induced and miscellaneous variety. If these patients ended up on the ventilator, fibrotic pneumonias, 100% mortality, but lower with drug-induced and miscellaneous ILDs. What it means is, if you are ventilating IPF, this patient is bound to die, and that is why it is very important for you to diagnose what variety of ILD you are dealing with, and if it is drug-induced or miscellaneous, there is a chance this patient might come out. So to summarize my talk, acute diffuse parenchymal lung disease, always consider a broad differential, including infections. BAL is definitely needed to exclude infections. Decisions on transbronchial and surgical lung biopsy must be individualized depending on the clinical scenario. Both might be justifiable, particularly if you feel that you can change the management. Invasive ventilation is a big no for IPF and usually is the reason for mortality. Intravenous corticosteroid therapy in high dosages is the treatment of choice. Early steroid therapy has benefits. If it doesn't work, you can use cyclophosphamide. And if it is vasculitis, use cyclophosphamide. This is the group I practice with. Quality care is needed for ventilating these patients, and that's how I'd end my talk. Thank you.
Thank you, Dr. Harjeet, for an excellent presentation. Any question for Dr. Harjeet on ILD?
Yes, yes. That was surprising. So what happened was this patient had received 5 grams of methylprednisolone. And following that, she was given rituximab, and she landed up with acute distress. So the problem for us was, should we give more steroids? She had already received 5 grams. So there was a big dilemma. So our leaning was this has to be something which is not responding to steroids. So infection was a big differential there. And that is why we had to do that BAL at the outset. But what happened was the patient got intubated, we didn't do anything, the patient got better. And retrospectively, we believe, because the patient cleared up in 4 days, that this patient had probably drug-induced. Because we grew nothing on the BAL, nothing at all. And we looked at opportunistic infections, fungal infections, the works, cytology, nothing came up, nothing came. And we gave her, 40 milligrams 12 hourly, because we were suspecting infection, because she had received 5 grams. Yes? The pathology of drug-induced ILD, well,